So welcome everyone to the Circulation, Arrhythmia and Electrophysiology webinar. This is a webinar series that was initiated by Dr. Paul Wong, who's the editor-in-chief of the journal, and Dr. Dan Morin, who is the senior consulting editor. We're really excited about this webinar series and tonight's discussion about PFA. So I'm Dr. Andrea Russo from Cooper Hospital, where I'm the academic chief of cardiology and director of electrophysiology. And I'm joined here by my co-moderator, Dr. Elaine Wan, who is the associate professor of medicine at Columbia University Medical Center and director of electrophysiology research. We have a really amazing panel of experts who will give us an update on what's known so far about pulse field ablation. We'll start out with a short summary of the recent pilot trial that was published in Circulation, Arrhythmia and Electrophysiology, and this is entitled First in Human Experience and Acute Procedural Outcomes using a novel pulse field ablation system, the Pulsed AF pilot trial. And this will be presented by Dr. Atul Verma. He's currently the chief of cardiology and professor of medicine at McGill University in Montreal, Canada. This will be followed by a brief talk about technology by Dr. Vivek Reddy, who's professor of medicine and director of cardiac arrhythmia services at Mount Sinai Medical Center in New York. And then we'll conclude with a summary of what to expect in the future by Dr. David Haines, who is director of the Heart Rhythm Center and professor of medicine at Oakland University William Beaumont School of Medicine. Following the brief presentations, we'll have plenty of time for panel discussion and Q&A. So please send your questions via the Q&A function at any point, and we'll relay your questions to the panel at that point. So let me go ahead and turn this over to Dr. Verma.
Thanks so much, Andrea. So I'm going to go ahead and share my slides here. And is everyone able to hear me and see my slides okay? All right, great. I see some nods. All right, so thanks very much for this opportunity to present a synopsis of our publication on the Pulsed AF pilot results, which obviously was published in Circ-AE. And thank you very much to the journal for that support. These are my relevant disclosures that you should be aware of. So as already mentioned, the title of the paper was First in Human Experience and Acute Procedural Outcomes using a Novel Pulse Field Ablation System, the Pulsed AF Pilot Trial. And I think what makes this pilot study interesting is of course, the Farapulse pulse field system, which was pioneered in usage by Dr. Vivek Reddy, who will be speaking next, has sort of been the dominant system in publication. And so this is sort of another alternative system, but again, with a focus more on the PFA side of things rather than specifically on which system is better than which. So the idea here was that this was a first in human experience. We enrolled 38 patients as part of this first in human experience with the goal of being 40 patients. And you can see here as you look down at the patient characteristics that this was a very typical paroxysmal atrial fibrillation type of population. So you can see the age was relatively young at 62. The left atrial diameter was very, very normal ejection fractions. And, most patients had failed about one antiarrhythmic drug before coming to the lab. In terms of the system being evaluated, this is the Medtronic PulseSelect pulse field ablation system. So as you can see by this picture here, it is a circular shaped catheter with 9 gold electrodes. And you may perhaps recognize this from the old PVAC days, but the catheter was refurbished and redesigned in order to be able to deliver pulse field ablation. In terms of the waveform, these are bipolar deliveries using biphasic pulses. And when we talk about tailored field vectoring, what we mean is that some of the deliveries are coming from adjacent poles in terms of bipolar, but then the device is also capable of operating in a higher field mode where the bipoles are actually spaced one pole apart. And so that creates a completely different field dynamic, which turns out allows for delivery of more power and deeper lesions. It's a 25 millimeter diameter loop catheter. You can basically map from the device, and you can also ablate from the device. It is over the wire. We used a custom PFA generator designed by Medtronic. There is a low voltage test pulse, which you deliver before you deliver to make sure that you cannot capture the phrenic nerve, because in preclinical studies, we found that if you do not get any phrenic nerve capture with the test pulse, it is almost completely unlikely that you're going to cause any stunning of the phrenic nerve with PFA. The deliveries are also synchronized to the R wave, and each button push delivers one train of pulses. So you actually have to deliver the button you have to push the buttons 4 times to deliver 4 trains, and that's kind of the minimum dosage per application. If we look at the inclusion criteria, there's nothing really special here. The patients had to fail at least one antiarrhythmic, and we actually included both paroxysmal and persistent patients in this first-in-human study, although the vast majority of the patients were in fact paroxysmal. So this was sort of the headline result here, which was the acute electrical isolation of the pulmonary veins. And, even though this was the first in human experience, and these were the first few patients that by about 6 different sites across the world. So that meant about 5 to 10 patients per operator. So no operator did a huge number of these procedures. And yet, in spite of that, we easily had achieved 100% isolation of all of the pulmonary veins, including some pulmonary vein variants, for example, with a left common pulmonary vein. Now, one of the things we realized early on in the experience, and this is something that I'm sure has been recognized by all of the different pulse field systems, is that this is the mapping on the circular catheter. That artifact you saw represented one train of delivery. So that's only one of the 4 that's mandatory. And you can see that even after that one delivery, you basically had complete isolation of that pulmonary vein. And yet we started to learn during this first in human trial that we had to do repetitive applications in order to get durable results. So this is one of the potential problems with PFA, is that the signals go away right away, and so they no longer operate as a reliable endpoint for determining when you're actually finished delivering PFA. This is an example, I hope this comes out okay, of one train delivered, and you can see that even after one train, you had some separation in the pulmonary vein potential. After the second delivery, you can see that the delay gets even longer, and finally you see entrance block in the vein. This was a nice example because the electrograms did not go away completely right away. And so you were actually able to see the progressive isolation of the vein. But more often than not, the result was more similar to that video that I showed you. In terms of the level of PV isolation, it was recommended for these first patients to have a mapping system on board. And so mapping was done with the operator's mapping system of choice. So you can see here, this is a post wide antral isolation as mapped by one of the electroanatomical mapping systems. And then this was a pre image followed by a post image. And what's kind of interesting here is on this mapping system, you can actually put a shadow of every time you applied around the veins. And as I suggested, the recipe was that we should make at least 8 deliveries per vein. So you can see that there were multiple sites of delivery in order to be able to isolate the veins. Now, keep in mind that even though we're talking about 8 deliveries, each of these deliveries is a fraction of a second. So if we look at the procedural characteristics, what was pretty impressive in these first 40 patients so early in the learning curve is that we were already dealing with an 82-minute procedure, and that included a mandatory 20-minute waiting period at the end of PVI. So if you remove that 20-minute waiting period, the procedure time was already about 60 minutes, so early in the learning curve of this device. It was also interesting that not all of the patients received general anesthesia. So we did show that, in fact, conscious sedation was an option for this system. The patients who received conscious sedation did feel a little bit of vague chest discomfort, but usually with a little bit of extra sedation, they were able to continue for the rest of the procedure. And then finally, we kind of went straight from the first in human pilot study to rolling it into a much larger pivotal study, which is called the PulseSelect study. This is a single arm study with 418 patients, which again will include both paroxysmal and persistent AF patients. Subgroups will undergo assessment for PV stenosis and cerebral MRI. The trial enrolled incredibly quickly in spite of there being a pandemic. And so we're actually going to be ready to present the 1-year results early in 2023. And I think I'll wrap it up there.
Great, very, very exciting, and we're gonna. I'm sure there'll be lots of questions regarding that. So we just have we have three presentations, and we'll have the questions and answers, during the panel discussion. Certainly, really nice to see those signals go away so quickly. So, the next talk is Dr. Reddy.
Hopefully, are you seeing the correct screen here? Is this incorrect?
Yes. We got it. Thank you.
Fantastic. Okay. Thanks again to Circulation Arrhythmia for the very kind invitation to speak on this panel. So my charge was to discuss some of the different technology options, and there's a number of them. I'll go through the ones that I'm aware of, which means there's probably a bunch of others that I'm not aware of, and I apologize to anyone who I omit. I have a number of disclosures, and very importantly, please note that none of the devices that I'll be talking about have regulatory approval in the United States. Some do have approval in Europe, and I'll speak to those. I think one of the very important points, and Atul alluded to this, is there's a number of different parameters that affect the pulse field, both in terms of the size of the field, effectiveness, and probably safety, etc. And this has to do with aspects of the pulse waveform itself, of the catheter itself, and a number of other aspects that we probably don't fully understand. So I think the point that really matters is that PFA1 is not equal to PFA2. Certainly that's going to be something we have to keep in mind as we go across technologies. But even within a technology, as you go from one waveform to the other, the rule probably applies. So remember that as we now look at some of the catheter technologies that are available. So the first device that was tested was this pentaspline catheter that could be deployed as a flower or as a basket approach, an overwire the system that's positioned around the pulmonary veins to isolate the veins, as well as posterior wall ablation. And initially, it was designed to be used by itself without a mapping system, though it has been used with mapping systems. And this is one of the two devices that does have CE mark approval. And a lot of the first in human trials have been performed with this technology. And this is part of the Advent clinical trial, which enrolled patients with paroxysmal atrial fibrillation and is in the follow-up phase. There are other similar devices that have basket-like configuration, albeit different approaches, being tested in Europe as well as in other countries. So this is one such device. It's a hexaspline catheter being tested in China, also over the wire system. And there's a number of others. We just heard from Atul about the over-the-wire PulseSelect technology. There's also this one. This was a sort of a traditional lasso-like technology used with a with a defibrillator pulse. This is from Fred Whitcomb's group, and Peter Lowe and Kars Nevin and colleagues published some of the first in human data with this a couple years ago. There's also the circumlinear catheter that has a variable loop dimension that is linked with the mapping system as you shown here, so that it's positioned around the atrium so that you can create a series of pulsed applications and concatenate all of these to achieve the lesion set that you desire. And there are other novel configurations like this globe catheter, which has it's a complex device, but the goal is to make it a simple procedure. Multiple electrodes, each of which independently can be selected to deliver the pulse train. So the idea is push it up against the vein, whichever electrodes are in contact, which can be assessed by multiple approaches, you simply select those, or actually the system selects them, and then you apply the electrical field. There's also the concept of PFCA. So the idea is taking this cryo system that's shown here, putting up against the vein and delivering pulsed electrical field to create a lesion that may have some advantages in terms of microbubble formation, patient movement, and even depth. These are all sort of the single shot technologies or regional ablation catheters that are used to create your lesion set. They're also the focal catheters, because we do have to remember the majority of AF ablations done in the world today are using focal ablation catheters, somewhere in the order of 70%. And so this is the other CE mark approved system. It's actually not a catheter per se, it's just a generator, but it creates pulse electrical fields, and it's been tested with several different commercially available force sensing catheters. And that's now approved in Europe. There's also this lattice tip catheter, which can deliver both radiofrequency energy as well as pulse field energy. And this is part of an FDA trial looking at persistent AFib patients that is enrolling currently in the United States. And then there's other conventional force sensing catheters that also can deliver RF or PF energy. So when you look at all these catheters, and again, I'm sure there are others that have started clinical trials and that I'm not aware of, but if you look at these are the ones that are currently in clinical trials in the United States. Atul spoke about the PulseAF trial, the Advent trial. So this is paroxysmal and persistent. This is paroxysmal. This is ongoing paroxysmal patients, and this is ongoing persistent patients. And so, as Atul said, trials are enrolling very quickly, and hopefully we'll start seeing some clinical data in the not too distant future. I want to end with this. How do we differentiate all these technologies? Well, I'm just going to give you a couple of things to think about. Efficacy, you already heard from Atul, the occurrence of reversible injury. And just as with thermal energy, you can have acute isolation that reconnects. And I think it's particularly true with pulse field energy. So we need to understand durability. Ideally, with protocol-driven remap procedures, but minimally in patients that come back with clinical recurrences to understand whether or not the PVs are isolated. And of course, clinical effectiveness on the safety side. And again, each of these technologies, again, need to be understood. Do they cause esophageal damage? Do they cause permanent phrenic nerve injury? Will they cause PV stenosis? PV stenosis is one of those areas that I think we're going to see uniformly, probably no issue, but again, we'll see. Microbubbles, I personally am not concerned about microbubbles. Stroke is an obvious issue. I think these are separate issues, but again, we need more data. And coronary spasm, this appears to be something that if you're adjacent to a coronary artery, you cause spasm. It's certainly true with a couple of the pulse field technologies. Will it be a class effect? And that's something we need to understand. And of course, how do you mitigate that if you're next to a coronary? And then there's general workflow issues. One of the things about pulse field, you can cause muscular contractions with certain pulsed fields. You can cause coughing, which can be very problematic, and patients can move, which is a particularly important issue if you want to use a mapping system. And of course, we're going to be thinking about same-day discharge when you're talking about half an hour to 45-minute procedures. And I think this is going to be an important issue. What is the right kind of imaging? I should put imaging in quotes. Intracardiac ultrasound, fluorointerrogation, electroanatomical mapping, and there's probably other approaches to use. And that's something that the field will work out. Thank you very much.
Oh, that was great. Thank you. Certainly a lot of different, options, out there, and lots to learn. That was terrific. Let me now turn this over to Dr. David Haines.
Hi, everybody, and I appreciate Cirque A&E and Andrea inviting me to participate in this presentation. Let me get my screen up here. There we go. Okay, can people see that okay?
Yes.
Okay, ready to go here. I appreciate the opportunity. I'm going to just give my spin on things, hit a couple of high points. And Devi Nair is caught in some airport or up in the skies right now. So I'm going to touch on her topic as well, which is complications. Here are my relevant conflicts of interest. So, you know, we've been hearing a lot about PFA for a while, and there are a lot of promises that are being made in this field, including shorter procedure times, high efficacy, tissue selectivity, and low complication rates. And the question is, where are we, and how is this shaking out? To look at the efficacy side of it, one of the striking things about this is that you deliver a single pulse and bam, the electrograms are gone. And anyone who is watching a pulse field ablation procedure for the first time, the uniform reaction is wow, because it looks like one button push and you're done. Unfortunately, that is not the case. There are recurrences, and this is Vivek's trial back from 19, but still very instructive in that during the development of the FARAPulse system, they did an iterative clinical trial and tweaked the waveform. And Vivek mentioned how waveforms are all different, and all those parameters make a difference in terms of ultimate efficacy. And at the end of it, they achieved just this incredible outcome of 100% efficacy. Like, what in medicine is ever 100%? So we were all very impressed by this. So there are unknowns, though. There, you know, the mechanisms of the differential tissue effects, the optimal lesion parameters, and we need to sort these things out. And that trial gives us one view of the world, but an anomaly of this field is nobody knows what the waveforms are, because these are tightly held secrets by our corporate partners. And I wish that FDA would step up and say, you know, you have to disclose, because we on the user end and on the investigative end are really hampered by not knowing what these different waveforms are. So I have often stated, once you've tried one pulse field ablation system, you've tried one pulse field ablation system. You know, everyone is different, and you can't necessarily generalize observations. And Vivek did a nice job reviewing the technologies that are out there. There are a lot of them. And pulse field ablation, even though it seems to be highly effective, there is recovery of function. Remember, reversible electroporation is how this field got started, injecting DNA and other macromolecules into cells and maintaining viability. So there is this penumbra around the lesion that is reversible. And the time course of reversibility hasn't entirely been sorted out in the myocardium. And so here's one clinical case where the acute result looked great, but clinical recurrence, and you can see a lot of return of voltage on this example. So we still are understanding how much do we need to ablate, and what are the factors that will lead to effective ablation. So Dr. Verma, I may quote you, go big or go home. And this has been kind of the credo of all of us who've done these trials in ablation. We have multiple settings. on the dial for voltage delivery and magnitude of effect. And after the first couple of cases, or often after the first couple of lesions, we just say, okay, turn it up to the max, to the point that FDA is saying, why do we even have lower energy settings if no one is using them? And this is an issue that is unresolved at this point. Now, one of the great things about pulse field is myocardial tissue selectivity, and we hope that's going to translate into low complication rates. And here's a great study out of Bordeaux where they did MRI post-RF and post-pulse field with attention to the muscularis of the esophagus. And look at this, there is no injury to the esophagus. And this correlates with what we have seen in the preclinical studies, where the esophagus, the smooth muscle, is, for whatever reason, relatively resistant to injury from pulse field. And nerve, vagal denervation and other nerve injury, nerves seem to be relatively impervious or resistant to injury from pulse field. Now, the ganglionic plexi probably can be ablated, and there are a couple of people out there working on that, but peripheral nerves like the phrenic nerve seem to be relatively insulated. The pulmonary veins and other vascular structures do not have the same response as hyperthermic techniques, which cause shrinkage of the collagen and elastin. You know, that's the way bovies work, right? They cauterize vessels so you don't bleed. So in this trial, we did preclinical trial intending to injure the vein. We could do so effectively with RF, but pulse field, it was almost impossible to injure the vein. And you can see arterial injury, the pulse field arteries are preserved. Now, there are effects of pulse field on coronary arteries. With this case report, we see coronary artery spasm with pulse field delivery in close contiguity to the circumflex artery. So beware of that. That can and will occur. Now, this is the area that concerns me, and that has to do with bubble formation during pulse field delivery. And we think that these are electrolytic bubbles, and we think they're non-thermal, and we think that there's not particulate debris forming, and we think that these are safe. And so that's been the premise going forward with these systems, but we do generate bubbles. And here's a unpublished study from Andrea and Natali showing with transcranial Doppler showering of bubbles after PFA delivery. We all know the story of asymptomatic cerebral emboli after RF ablation. And here, these are examples after RF ablation. And we know that with RF ablation, we can get local excess heating, and we can get little coagulum formation and particulate embolization and gas embolization. And as a result, there was a reported ACE rate with RF of 4 to 45%. Now, you know, you can debate whether ACE lesions have any relevance, but it is cerebral injury. There's no question about that. That's pathologically demonstrated. The PulseAF trial that Atul just mentioned did not show any cerebrovascular events, but the MRI sub-study of the pivotal trial is still pending. Now, the 5S study, which used the FARAPulse system out of Europe, I think was a warning shot across the bow. They looked with a MRI in a subgroup of 53 patients and showed a 19% prevalence of ACE lesions. That is not trivial. If you look at Vivek's trial, the Manifest PF trial, look at their complication rate, they had a 0.4% stroke rate. Now, you know, these are big sheaths, there's technique involved, there's potential for significant air entry with catheter exchange over a large bore sheath. You know, there are multiple potential mechanisms, but, and Vivek, I'd be interested, your publication did not report the ACE rate, but you presented it at ERA, and that was, again, 17.5%. So not too off from the 5S results. So the question is, what are the optimal parameters for pulse field efficacy and safety? How big is too big? And with AF ablation, obviously, if you ablate all the myocardium, you're not going to have AF. And I've seen at least one post-ablation voltage map where there was no purple on the image. It was a little bit scary, and we all know more aggressive ablators out there that keep going until there's no AF. Well, you know, is this victory? Is this acceptable? Looking to the future, AFib is obviously the big market, but this is a great energy delivery system, and ventricular ablation is right around the corner. We need to increase experience, fine-tune tools for delivery. But the most exciting thing, I think, about pulse field delivery in the ventricle is what things look like with delivery on top of healed infarction. And we know that delivering RF over healed infarction is fraught with difficulty in transmitting the heat. And honestly, I don't still quite understand why, because scar is mostly water and it should transmit heat relatively well, but it just doesn't. But pulse field gets through the scar and gets to deeper tissue layers. And if you look at histological lesion depth, and this is a swine study with healed infarction showing that the depth of penetration with RF was kind of low, but with pulse field, it could get through the scar to deeper levels. This was Elad Anter's study, and this is at Gerstenfeld's study showing similar increase in lesion width and transmurality, ablating over healed infarction in a preclinical model. So I think this is going to be a big future application for pulse field. So the promise of pulse field ablation is mostly valid in initial reports, but refinements in catheters and PF waveforms should continue to improve things. The rate and significance of PFA-induced ACE lesions, I think the jury is still out. I think we need to know. An application of PFA to other arrhythmia substrates will be developed and may improve outcomes for catheter ablation, particularly in scarred ventricular substrates. Thanks.
That was terrific. Thank you, David, and all that gave a great understanding of what we know so far. You know, and I think everyone's thinking, well, there's going to be zero complications. Obviously, nothing has zero complications, and we see that when we start to look at some of the data. I guess, you know, as questions, I think there's at least one question that's already up in the Q&A section. But as people are sending in some more questions, I guess I would ask, you know, how are we going to, you know, define, or even in terms of durability? So there was one picture shown, the before and after. I don't know what the time period was between those, or, you know, how will we define there's recurrences clinically and what do we meet? What kind of standard do we need to meet to say this is, as durable or more durable than RF or cryo is I guess what we would like to see. How do we define that success?
Yeah, so maybe I'll take it, and maybe, I mean, obviously Vivek has done a lot of work on the early remapping, and obviously early remapping to demonstrate ongoing PV isolation is a surrogate for efficacy. We know it doesn't absolutely map out to long-term success, but it's a pretty good surrogate. I think the reality is, in the beginning especially, we're going to have to end up over treating a little bit. We know that delivering a single pulse will get rid of the signals and can knock out the signals even for up to 24 hours. So within a procedure duration, you may not be able to assess if this is reversible or irreversible. And in the beginning, I think we're just going to have to empirically say, okay, we're going to have to repetitively deliver here because the preclinical data says that's how to get a certain tissue depth. But ultimately, we're going to need a much better parameter intra-procedurally to tell us when we're actually done and when we've got a durable result. And what that is, I don't know. I have some guesses. But right now, I don't think anyone can say they have the definitive answer.
Andrea, let me just make a couple comments. One, the goal should not be to be as good as RF or cryo. That's fairly dismal. I mean, if you look at the actual clinical results from multi-center studies, it's really, really bad. I'll just give you one example. The Circuito study, I think one of the best done cryo studies that we have, the investigators published the durability rate in patients that came back for second procedures. And basically, it was 10% of the patients had veins durably isolated. It means 90% of the patients had at least one vein reconnected. And that's what happens in clinical practice when you're not focused like in a first-in-human trial or whatever. Similarly, the same thing's going to happen with pulse field. Hopefully, it won't be quite as dramatic, but it's going to happen to some extent. And so I think that, to answer your question very quickly, I mean, I think the remapping studies, like some of the ones that we did at 3 months, are great for showing what can be done in a single center situation, usually when everybody's focused on this issue. But when you get to clinical practice, we're going to have to look at any trial that's presented. I mean, I want to see the remap results for the patients that had clinical recurrences, because without that information, it's almost an uninterpretable trial for me, other than safety, of course. So, sorry.
No, I was just going to ask. So the remapping were those people, they was routinely remapped and without, even if they had no clinical recurrence. You
right. Obviously, that has the advantage. You get the information very quickly. It has the advantage that it's comprehensive, or at least nearly comprehensive. It has a disadvantage. You're only going to get it in the setting of a clinical trial and a difficult to enroll clinical trial. You're not going to get hundreds of patients in that kind of a study.
And so what percentage of those people actually had symptoms, I guess, would be the question, who were remapped and
at the time of recurrence? I mean, at the time of remapping?
Yeah.
I mean, we remap at 2 to 3 months, so the majority of those patients are not going to have symptoms. It's too early. Yeah, I mean, that's, yeah. Can I just answer? David asked a question, so I just feel like I should address that, which is the issue of the ACE rate in Manifest. Actually, we did publish it, David. It's in the supplement. We didn't put it in the main manuscript because it was only reported from 3 of the centers, 3 of the 25 centers. So, but it is actually in the supplement, that data. And yeah, anyway, so we just did that.
I'm going to go ahead with some of the other questions by the attendees. And we just wanted to reiterate, please, for the attendees, please type your questions in the Q&A. I know one of the attendees raised their hand, but we aren't able to have live chat. So please just type it in your Q&A box. One of the questions is, what is your approach for patients today with persistent atrial fibrillation, and how do you think that will change with PFA? I just want to elaborate on that question a little bit more, because one, I think before we started, we were chatting a little bit about PFA for proximal versus persistent, which Dr. Verma was talking a little bit. If you would do a trial, I guess like Dr. Reddy was talking about, there's focal isolation as well as the one shot. So if you were doing a trial for persistent PFA, would you do the one shot and then if there were lines, use focal, or what would your approach for persistent PFA therapy be?
Yeah, maybe I can give that the first shot. So I think you know, at the end of the day, PFA is not going to solve the problem of persistent atrial fibrillation. I think we still need to figure out what the best technique is, whether we just do PVI, whether we do more than PVI. And I think we've already seen that PFA efficacy is not going to be 100%. You know, it's going to be somewhere, you know, between the thermal energies, maybe even comparable to the thermal energies or somewhat higher. So we're not going to be able to answer the question definitively with PFA. If we durably isolate the veins forever, what's the success rate in persistent AF? Having said that, PFA certainly is flexible enough that you can really do whatever you want. So with for example, the circular shaped catheter that I was describing, even though it's over the wire, the catheter actually can be turned completely out into the posterior wall. So in the pivotal trial, almost all of the persistent AF patients received PVI plus posterior wall isolation, whereas most of the paroxysmal patients received only a wide antral PVI. So it'll be interesting to look at that data and see whether extension onto the posterior wall made any difference. Certainly when we were doing the space study with the Galaxy system, which was that generator that Vivek showed, it's a focal catheter system. So if you want to make a line, you can make a line. If you want to box isolate the posterior wall, you can box isolate the posterior wall. So as an energy source, it's remarkably flexible, and you can do whatever lesion set you really want.
Great, thank you.
I
Actually,
would echo that, but add also that PV isolation is and forever will be the standard in ablating paroxysmal and persistent AFib. We do have a number of promising AFib mapping systems that are in the pipeline, and they will help us be more selective in terms of identifying critical substrates for modifying ongoing persistent AFib. So I think that getting durable PVI rapidly, effectively, safely will be the mainstay for all AFib patients. And so I think PFA is going to be a huge factor in moving us along that path. And then whether we use focal ablation tools with PFA or RF or whatever to do subsequent modification of other substrates, you know, I think that we need to learn more or understand more about the varying types of AFib, and these mapping tools will allow us to better phenotype the subsets of persistent AFib patients.
Mm-hmm. Actually, Dr. Haines, thank you so much for your presentation about the possible pitfalls. You were talking about pulmonary vein stenosis and cerebral, the microbubbles. And I was surprised you didn't mention it because when you said go big or go home, are you concerned about the amount of atrial tissue dysfunction from all of the ablation? Is that something you think we should investigate more, like long the line follow-up after ablation, how much fibrosis there is and how much atrial strain or atrial function is left after a complete ablation with PFA?
You know, I'm an old guy, and I remember back in the day that we in the EP community were scrutinizing the results of our surgeons doing maze operations, and we would be the fleas annoyingly buzzing around saying, but what about atrial transport function? You can cut up these atria and sew them back together, but do they work when you're all done? It no longer is politically correct ask that question, because we are now the ablaters, we are now the operators, and we sort of said it's inconvenient to dig into that too deeply. I do think that pulse field has a great advantage in that it does not cause injury to the structural protein. So collagen, elastin remains, and the horrible complication of stiff atrial syndrome, I hope, will not be an issue after pulse field, because that's a terrible outcome and there's really no fix for it. But I am very concerned in patients who have no viable myocardium. And I do know a couple of operators personally who aren't concerned about that. I am concerned about that. How about you? Are you concerned about that?
Well, no, I mean, look, I think your point is well taken. And the one thing I was going to say, I just didn't think it was important enough because you already said it, was that when people get these technologies for their clinical practice, I can tell you, it's very seductive to spend 2 seconds to turn something red. And it's very seductive to say, oh, you know what, why don't I just ablate over there, and then over there, and then over there, and over there. And suddenly there's nothing left to ablate because everything is red. So, and I think that in our field, we've come, because of our inability to get durable lesions with thermal ablation, we've gone more and more and more and more. And sometimes that may be appropriate, but I think what we're going to find is that if we can get good lesions with pulse field, we probably don't need to do as much in everyone. And I would just encourage people to be a little more conservative in terms of your lesion deployment, certainly in the beginning.
And the one thing I guess I was still thinking about is that the circumflex spasm. So we're thinking of a selectivity, and so a little bit surprised. Are you close, or how close is too close, or is that just it was one single case report, or any thoughts on why that we seem to be so safe, by the esophagus or safer? What makes the artery different? Is there,
Well, I think at the end of the day, the artery is not going to be damaged even if it undergoes a period of spasm. So we've been doing some preclinical data where we have intentionally been applying PFA in proximity or right on top of arteries, and I don't think we're going to see any evidence of long-term arterial damage. The problem is the not insignificant problem of having spasm during the case, because that obviously can cause symptomatic ischemia, that can cause ECG changes. Although, as Vivek has shown, not all of these cases of spasm are actually associated with clinical symptoms. So spasm may be happening subclinically and we don't even know it. So I think and Vivek, I'll leave you to talk about this, but I think with, appropriate pre-treatment, knowing when there is a risk to have it happen and when there's not a risk to have it happen, it's probably not going to be a major issue or a major cause of morbidity for patients or mortality for patients. I don't think it's going to be a serious complication, but it's one that we have to be sensitive to.
Yeah, no, thanks. So we have a paper in circulation that's in press right now that you can find online if you're interested, where we purposefully ablated next to a coronary, so CT isthmus lines, and these are things that are being done in Europe as the device is approved. And what we saw when we shot the coronary, and by the way, the reason we did this was because of the case report that David showed earlier. When we shot, what we saw was subclinical coronary spasm that was almost universal. So there is a proximity-related coronary spasm that clearly occurs, probably occurs with most, if not all, pulse waveforms, at least the ones that are being used clinically. But again, all these need to be tested. And it does seem to be responsive to pre-treatment with parenteral nitroglycerin. So you can attenuate that. What's the right dosing and all that still needs to be worked out. I just want to remind people there's a different type of spasm that occurs, the more generalized, horrific spasm, we'll call it, that happens in the Prinzbill type patients. And that was actually described at first with I don't know if it was first, but it was certainly described with cryoablation. In fact, there's a very large literature from Japan on the sort of generalized spasm that occurs, and that's a really big deal. You'll get cardiac arrest and things that you just have to be aware of. And it seems to happen with pulse field also. So I don't think that's anything special with pulse field, but it can happen with pulse field too. So there's two different types of spasms one has to be aware of.
I think we should just go quickly for some of the last questions since we have 8 minutes left. Martha, thank you for joining us. Her question is, how does PFA fit in with the recent results from the low voltage ablation trial?
First, we have to understand the low voltage ablation trial.
Yeah, so what an interesting result. That was the Erase AF trial, which Helmut Purefellner did and published in the new journal NAJM Insight, which showed that ablation of low voltage areas in the atrium plus PVI actually showed an advantage over PVI alone. So it's one of the few persistent AF trials where there's actually been a discernible benefit to doing more versus not doing more. I think all that to say, I think PFA is going to be a very good energy source for low voltage or high voltage atrial areas, in the same way as when David was mentioning the ventricle. It's going to be very effective, I believe, for both scarred and non-scarred tissue. And we've certainly been seeing in our MRI results that PFA penetrates scar, even large areas of scar, very, very well. Because as it turns out, scar is actually low impedance compared to normal tissue. It's not something we think of because we sort of think of old scar as being like shoe leather. And I always assumed that shoe leather had high impedances, but it turns out that it's actually lower impedance. And so scarred tissue is actually remarkably receptive to PFA.
And just to round this out, there's a question that's, have you ever performed SVC isolation with PFA? I guess that's also looking at other triggers other than the pulmonary veins. Have you been able to isolate the SVC with PFA?
I mean, certainly preclinically, I think every single one of these catheters have been tested already, and clearly it can be done with a low, maybe not zero, but very, very low risk of damage to the phrenic nerve. Whether or not you should do that clinically, that's a patient issue. That's not a technology issue.
Yeah, I think it's very well suited for that. And particularly the single shot catheters sit up in the SVC pretty effectively, at least in pigs, according to my personal experience. But I would anticipate it would be effective in humans. And there's pretty good data in terms of phrenic injury. It's a proximity issue, but even when you're right on top of the phrenic nerve, it's very hard to cause injury, and it's probably due to the Schwann cell insulation of the nerve, as well as the small diameter of the nerve, would result in less a voltage gradient across the axon.
Yeah.
Oh, sorry, go ahead.
Oh, I was just going to say that, you can, if you're really in proximity, you can stun a phrenic nerve with PFA. So it's not that you'll never get any phrenic stunning, but more often than not, and we've been seeing this as well in the clinical experience now that it's approved in Europe, those stunned phrenic nerves will recover well within 24 hours. Like usually by the end of the case or within the first 8 hours, the vast majority of them recover. So as David said, it's really hard to take out a phrenic nerve for longer than 24 hours.
Right.
Just one caveat to that. David, in your presentation, you brought up this question of if you have a range of dosing options and people are only using the high dose, should the low dose be approved? My own feeling is yes, it should be. And the reason for that is that there are situations like this and others where we may want to have a low dose. Is it going to be perfect? I mean, I don't know. but the field will figure it out. If we don't have that as an option, we'll never have that as an option. No, it is not reasonable. It's not even reasonable for us as users to expect a large company to spend tens of millions of dollars to do another clinical trial at a lower dose for our unusual cases. Not going to happen. So I
Right.
hope the FDA allows that.
Good point.
Yeah. Okay.
Okay, we're almost 3 minutes to the end of the hour. Andrea, do you have any final comments?
No, I think that was a great discussion. I think, you know, we're all obviously so excited about this new technology, and yeah, I guess we're not going to know for a while. There are differences, obviously, as you know, David brought out, and everyone brought out, between the different systems, and I guess we'll learn more about that over, you know, the next year or so. So no, I think this is exciting, you know, and hopefully, you know, this will hopefully have durability, so we don't, you know, we're much better, as is suggested, much better than RF and cryo, to have long-term results that we can do everything once and not have to go back in. No, so I really appreciate we really appreciate your expertise and sharing all your knowledge and experience with all of us. And thank you for participating, and thank you everyone in the audience for joining us. This will be also recorded for those who could not make it tonight.
Thank you very much.
All right, have
All
a
right.
great.
Thanks for
Thanks,
the
Andrea.
opportunity.
Bye-bye.
Okay. Good night.
Good night.